So I'd really like to thank the Water Research Foundation for coming in to give this presentation today. For those who don't know, the Water Research Foundation is the leading research organization advancing the science of all water to meet the evolving needs of its subscribers and the water sector. So it's a nonprofit, charitable, and educational organization which funds, manages, and publishes research on the technology, operation, and management of drinking water, wastewater reuse, and stormwater collection, treatment, and supply systems, all in the pursuit of ensuring water quality and improving water services to the public. So as we start off here, we have Jennifer Warner on the call. She is a regional liaison and senior account manager with the Water Research Foundation. She is New York City DEP's account manager. So, we reached out to Jennifer to set this up today. So I'd like to thank Jennifer for working with us to make this happen. And then, we are honored to have the foundation's Chief Innovation Officer, Christobel Ferguson, with us here today to talk about COVID and wastewater. Christobel has worked extensively in the utility sector nationally and internationally. She has served in transformative roles, leading teams engaged in research development, policy and planning, modeling and data analytics, quality assurance, resource management, and customer service. She has also developed a strategic overview of the US, Australian, and international water and environment sectors through her involvement with leading professional bodies, including the Water Research Foundation, the Water Environment Research Foundation, the Australian Water Association, the International Water Association, the American Waterworks Association, and the US Environmental Protection Agency. So Christobel has a biomedical science degree and a Master of Science from the University of Technology, Sydney, and a PhD from the University of New South Wales. Christobel worked as a microbiologist in the water, environment, biotechnology, and pharmaceutical sectors for Sydney Water, Burns Phillip, Reckitt and Coleman, Tertia Diagnostics, and Sydney Catchment Authority. So she's well known for her ability to lead interdisciplinary technical teams to solve complex problems in water information, policy, and planning. So she works to bring research and technology innovations to the water sector to achieve sustainable and productive outcomes for the management of natural resources. So obviously many topics that she could discuss today. She definitely has the credentials to be bringing this presentation to us. And she is here because of the interest from WRA members on this COVID and wastewater topic. So she is here to give us her huge insight into the data and information available. So Christobel, thank you for being here today. We really appreciate you taking the time to come and present to our WRA members. So with that said, I will go ahead and turn it over to you.
So this presentation is basically myself and Jen, and we're both really glad to have this opportunity to speak with you.
Thanks, Christobel. Thanks again, everyone, for having us today. As Jen mentioned, I work with DEP, and we were very pleased to be asked to provide this information to your association and to share the latest in wastewater surveillance research for COVID to understand community health. Again, my name is Jennifer Warner, and I serve our subscribing utilities and partners in the Great Lakes states, New England, and New York, including DEP. I've enjoyed working for the foundation since 1 week before 9/11, if you can believe that. I'm an engineer by training, but I like to think of myself as chief dot connector today. So which is one of the ways I'm able to bring Dr. Ferguson here to you today and share all that great insight that she has. Let me share just a very little bit about who the Research Foundation is for those of you who may not be very familiar. For some of you, this may be repetitive, but it might have some new information for you. And then we'll let Christobel move forward with what we're all here to learn about today. So Christobel, thank you. So for the most part, we are a nonprofit. We're a collaborative. We fund research. We were founded in 1966 under the auspices of the American Waterworks Association. Today, we seek to understand the full cycle of water. We do this by achieving 4 primary goals. Is a lot of data on this slide, but this all shows the many ways that we meet 4 intended outcomes for the funding that's provided to us. First, we generate and share knowledge. We fund research projects. We listen to folks like yourselves. We listen to our utilities. We listen to partners and stakeholders and regulators. And we fund projects that help answer questions for today's challenges. We make connections like this among peers in the water sector. We facilitate the uptake of innovation. That is primarily the paramount goal of Christobel and her team, is to bring innovation to our subscribers and help decision makers ultimately make decisions with impactful research results. We do this by funding 264 active projects today, and 84 cents of every dollar goes to research. So we're really proud of the efficiencies that we have, and we're mostly funded by utilities, but not entirely. There is recognition that all water is one water. So Christobel, you can move to that next slide, please. We all, I think, understand this today, but I think it's an important reminder that, especially for a receiving water basin like yours, that it's all recycled. It's all the same drop of water. It just is utilized in a variety of ways. And unfortunately, because of that, because we've got rain and stormwater, groundwater, wastewater, recycled water, and drinking water, you've got layers and layers of institutions and policies and people reflective of all those different drivers for those water types. And that makes it difficult, but we're here to help. Next slide, please. I wanted to call attention to some of our common partners. I took a look at your website and I saw a lot of common partners. So I hope we can keep the conversation going. I thank those of you here today for listening in, and I thank the folks on the screen for obviously a commitment to improving who we are and what we do by not only being a member of the Water Resources Association of the Delaware River Basin, but also the Water Research Foundation. So with that, please, Christobel, you have received a wonderful introduction. So I'll stop there and let you go. Thank you.
Thanks very much, Jen. So just an overview of what I'm going to take you through today. First of all, highlighting the rapid collaboration that happened right at the beginning of the pandemic, and the role that the Water Research Foundation played in helping to bring some of the existing knowledge together. I'll then take you through some of the global applications, different ways that wastewater surveillance was implemented around the globe, and highlight some of the findings, some of the research approaches that were implemented. We did a recap of that in April 2021. So I'll highlight some of the things we learned then. And then I'll touch on, what have we learned over the last 2 years? Like where are we at now with wastewater surveillance? And what do I see as the knowledge gaps and the potential future opportunities for this type of work? And if people want to jump in with questions at any point, feel free to do so. Happy to answer questions as we go along. So right at the beginning, this happened about 7 weeks after I arrived in the US. 11th of March 2020, the WHO declared a global pandemic. In early April, the Water Research Foundation decided that it would be a good idea to try and bring together international experts in the field of virology, public health, wastewater, to really try and coordinate some of the research efforts that we could see were springing up across the globe, and to try and see if we could provide some help in terms of coordinating those research efforts to really quickly produce results. And so by April 27th, we actually launched an international water summit. We brought together 53 experts from 7 countries to discuss how wastewater could potentially be used to track COVID-19, and also to identify what the priorities should be in order to conduct research that would help use that information to support health decision making. So what would be the things that people would need to see in order to have confidence in this data to really be able to use it to support decision making? So it was a very quick response. We were able to bring those people together, and we asked them to focus on 4 key areas. So we recognized very quickly that how to collect the samples and store the samples would be really important. We wanted to try and use existing knowledge to bring some sort of consistency and advice to people on how to go about collecting the samples and storing the samples, and then what kind of tools were available to focus on actually detecting the genetic signal. So even in the very early days, there were multiple methods that were being touted as the way to actually test for the presence of SARS-CoV-2 in wastewater samples. And we wanted to see if we could, use the group's collective knowledge to try and identify the way forward. And then a third group focused on what would we do with that data? How would we actually take that data and be able to use it to inform the public and health officials about what was going on? Would it be able to tell us about trends, or would it be able to give us any indication of community prevalence? How could the data actually be used? And then fourthly, we also wanted to focus on the strategies to communicate the implications of wastewater surveillance, because we recognized that this was going to be something that was not your standard health approach. So it's not like at that time, doctors or epidemiologists were routinely using wastewater data to inform the status of disease in the community. It has been used in that way previously, but it was not a widespread or accepted practice. So we recognized that there were going to be a need to understand how to communicate the information both to health professionals, but also to the general public as well about what we were doing. So in doing that summit, the use cases that were identified, the group felt that being able to detect trends would be possible. So looking at increasing strength of the signal in wastewater should be able to tell us that there was an increasing amount of disease in the population being served. And we felt that it would also be able to track the downward trend as well. So even as early as April 2020, the group felt that being able to detect the trends going up and coming down would be possible. However, it was quite clear that we wouldn't have sufficient information to be able to detect community prevalence. So the group felt that trying to extrapolate the information about the genetic signal to say, okay, that means now we've got 10% of the population infected in this area, it just wouldn't be possible to do that because there were too many other variables that were not being measured. So it was very quickly realized that it would be useful for trend analysis, but we didn't think it would be able to be converted to a community prevalence rate at that early stage. And so that was an important finding, because that then meant that when we were talking to people about wastewater surveillance, we wanted to sort of put that boundary around it, because we were concerned that if people did try to extrapolate the data too far and use it in that way, it would then not hold up. And so then people would lose confidence in the approach. So this was something that was identified pretty early as not wanting to put the brakes on it, but wanting to put, clearly state what the limitations of the technique might be, so that people would not, be disappointed if or use it in a misleading way. So in these early stages, in this first, workshop and international summit in April, we very clearly identified that you could use the sewer shed surveillance data to track trends in infection. Particularly, we felt for early detection of the disease in areas where it may not have been detected previously. We felt that it could be used to see hotspots, so where there were large amounts of the virus occurring. There was a lot of discussion about the risk to utility workers and those that were exposed to raw sewage, because at that time we did not know whether the genetic signal that was being detected in sewage was actually live virus or whether it was just genetic fragments. And there was also interest in whether you could use wastewater to source the track of the virus and to look at the evolution of the virus. At this time, we thought that it probably wouldn't, these last two use cases, we wouldn't have enough information to be able to do that. So that was certainly the case in April 2020. What we did was we then summarized all of that information, put it into a white paper, got it up on our website. I think it was up there by about May 2020. People started being able to refer to that. There was information in there about how to do the sample collection and what we recommended as the future, research needs. And the highest priority research need that came out of the summit at that time was the need to do an interlaboratory and method assessment comparison. At the time, it was felt that this could be quite difficult because we already recognized that there were upwards of 30 different methods that people had already developed and were rapidly publishing and putting out there, but no one knew how these methods compared to each other. And so this was identified as the highest priority by the summit participants. And they said, second to that, we would also need to understand the other factors that affect the detection of the genetic signal and the variability of the genetic signal in wastewater. So things like if you get rainfall and you have inflow in your sewage treatment plant, how much does that dilute out the signal? If your sewage treatment plant has a very long collection system, how much decay would you get in the signal from, while it's in the collection system, those kind of things. So these two projects, these two highest priority research needs were actually funded. We put out RFPs straight after the workshop, and we actually were successful. We attracted funding from the Gates Foundation as well. So the Gates Foundation joined us in equally funding these top two research priority projects. The first one, the interlaboratory methods assessment, we commenced pretty much immediately, and that was delivered by September of 2020. So that was a very short duration project to try and get that information out to the water sector. The second project went for 12 months, and so that was a bit longer. The other projects that are listed here, we added SARS-CoV-2 to some of the existing projects that the Water Research Foundation already had ongoing. So we had a number of projects, particularly with the California State Water Board, where we were already measuring pathogens in wastewater for a different project, for a different purpose. And we were able to add SARS-CoV-2 to just expand the scope of that project to include it in those projects. Same with one that we had on Lassa virus. We're looking at persistence and disinfection of Lassa virus, and we added in the SARS-CoV-2 to try and have a look at that worker health and safety aspect. And we also were asked by Kyle Bibby and his colleagues to support an NSF-funded research coordination network, which we saw as, it was only a small role for the foundation, but our role was to help with the dissemination of the work that the research coordination group were doing. And so that was a 12-month project as well, where we supported that network to help them distribute the results and make them widely available to folk. And so the first project, the 5089 project, this one, we actually had a couple of publications come out. We actually got those up pretty quickly as open access journals so that people could get access to those methods. We had a webcast to describe the methods. So Trussell Technologies from California did this work. All of the methods, the SOPs and the quality assurance plan and everything are up on our website. So if you care to look at that, you can certainly access that material. The importance of this work really was that it enabled us to compare these widely different methods that were being used to detect the genetic elements of SARS-CoV-2. Quite a lot of different approaches that were being undertaken. And I'll just give you a snapshot of some of the results of that trial, because it was significant in terms of the bottom line was that what we found out was that there were a lot of the methods were comparable. You could actually use all of these different methods to detect SARS-CoV-2, and it would still be useful in terms of wastewater surveillance. So I'll just step you through this first graph here, which is showing that we divided up the methods by whether or not there was what type of concentration step was used on the wastewater initially, and whether or not solids were removed from those samples. So the first method 1 and 1S, that is no concentration whatsoever. So straight analysis of the primary influent to the plant. 1S means that the solids were removed. Method 2 was ultrafiltration of the wastewater with or without the solids removed. The third one was the HA filter technique. So this is a common filtration technique. And then the fourth method was polyethylene glycol precipitation, which is also a very common method used for detection, concentration of samples for viruses. It is a more labor-intensive and time-consuming method, so that does limit. It's more, I guess, onerous to do that method. What it did show, though, was that there was wide variability if you were using like the straight wastewater. without removing the solids. But if you remove solids, you tend to actually, reduce that variability. So quite a bit. The methods that ended up being most, reproducible particularly were the ones with the filtration step applied and the one with the PEG precipitation applied. So, but there were a large number, you can see here, the different, even within those methods, there were still different SOPs that were being used. So people were doing slightly different steps, even if they were using the same type of concentration technique, the standard operating procedure might still have some differences. And these reps refer to the number of different labs that we had that were doing that particular method in the trial. And these are the overall results in terms of reproducibility across the methods after the QA and QC filter has been applied. So surprisingly, across all of the groups, 80% of the values fell within a 1 log range, which I thought was, as a microbiologist, was quite amazing, really, level of reproducibility. Obviously, there are some, that were better than others, but still, it was really quite reproducible. I mean, it was quite reproducible considering the wide variety of approaches that were being used. In this graph, the N1 and the N2 refers to the gene primers that were being used, the CDC gene primers N1 and N2. These gene targets, these primer sets are the ones that are most used across the sector, while some other groups are using other primers. Almost all groups were using at least N1 or N2, so at least one of the CD primer sets, if not both. So that was certainly one consistent element in the methods in most cases as well. Just highlighting here that when you look at the reproducibility, these filtration methods and the PEG precipitation method gave really tight reproducibility within that group. And if you corrected for recovery, because all of these methods, people are using an internal control to look at their matrix spike and to look at the recovery. If you use that recovery, it generally brings the concentration methods in line with the no concentration methods. But not everybody is actually doing that adjustment with their results. So even though they do use the internal primer, internal control to look at their recovery, they don't always adjust the signal strength for the recovery. There wasn't really a systematic impact from solids removal step. And we did see that some groups preferred to use the solids and other groups preferred to, not use the solids at all. So it was different approaches, but one thing to note with this, when you were testing solids, is that because of solids retention time, it tended to be the sample would represent like a larger time period of effluent coming into the plant. So the conclusions from that trial were really that multiple methods could be used to get reproducible results, and what was recommended was that wherever you were setting up a program, people should pick a method and stick with that method. So basically, as long as you were using your method consistently, then it was okay to compare and track trends over time, because basically you're not swapping and changing methods. That way you can be confident that the changes you're seeing are related to the change in the actual amount of genetic material there, not actually a change in your methodology. It was felt to be important that recovery efficiencies are measured, because there was a lot of difference in the sensitivity of the methods. So some of the methods were much better at detecting low levels of virus than others. So for example, if you were directly analysing wastewater, the level of sensitivity wasn't as good. So while it was easier and while it was quicker and it was reproducible, it meant that as your epidemic started to wane and levels of SARS-CoV-2 in sewage went down, it would get to a point where you would start to get non-detects, because your method just wasn't sensitive enough to pick it up. And it was thought that matrix spikes are really critical to quantify recovery and to just have confidence that you're doing your method reproducibly over time. in terms of tracking trends, yeah, it was important to, if you needed that higher sensitivity to allow you to track over a wider range of concentrations, then you needed to be considering the methods that actually had that greater sensitivity. And generally, they were the ones that involved concentrating the sample either through the filtration or PEG precipitation. So that was published pretty quickly, and certainly by September 2020, there were many groups that were actually setting up projects across the globe. So here in the US, some of the big ones were put together by DHS and the CDC with Aquavitas initially. It's now, and the CDC also now has the National Wastewater Surveillance System, and they did a pilot study first, but they're now in the process of expanding that. There were private companies as well. BioBot started doing a lot of pro bono work originally, and then started charging folks for those samples. So BioBot has certainly come into the market and doing commercial analysis. US EPA had a research project with the Cincinnati, Ohio location with the water utilities there. In Canada, the Canadian Water Network did a method evaluation as well. So similar to the project that we did, but I think about 7 or 8 laboratories. We would have liked to have included them in and done our trials together, but at that time trying to get something across the border was just not going to happen. So we had to run them as separate projects. So they did their own evaluation, which found pretty similar results to our project, which was reassuring. In Australia, the Water Research Australia put together what they called the Colossus Project, which involved a number of different universities and water utilities and groups across the country doing a national project. And in the Netherlands, KWR Water Cycle Research Institute continued to do method development and really look at the factors that needed to be taken into account when getting the genetic signal. And Herchen Medema at KWR was the first person who actually flagged that we could use sewage to track COVID-19 and was the first person to sort of suggest it and kick the whole thing off. WRC, the Water Research Commission in South Africa, also did pilot projects and method development projects. And subsequently, the European Health Emergency Preparedness and Response Authority worked with KWR to actually expand the wastewater surveillance in Europe to quite a number of countries as well. So there was a lot happening within particularly the first 12 months. And as well as that, there were just numerous academic water research groups and water utilities across the globe that were working on how to actually detect the signal in wastewater effluent. And one of the innovations that came up, and this was Colleen McNaughton from University of California, Merced, put together the COVID Poops dashboard, which was tracking where people were doing wastewater surveillance across the globe, which universities were involved, what countries they were in, how many sites they had, and then how many dashboards were being set up. Some of the dashboards were open to the public, others were for public health agencies only, but you can see that there's been like a huge number of programs that have been set up across the globe. And so that was really kind of the first 12 months. And when we were getting towards April 2021, Water Research Foundation, we had a discussion around, would it be a good time to kind of take stock of what's happening? And really the focus of this global review was to look at how is the data really being used, because we knew a lot of people had taken up the methods and were developing the methods and using the methods. What we were really trying to get at is how was the data being used? Were the health agencies using the information to make health-based decisions and to guide what they were doing? And this was the question that we really wanted to see, how the response had been from the health community and how the information was being used in different locations across the globe. So we invited people to submit abstracts to take part in this global update. And we had an overwhelming response of people wanting to take part. In the end, we had to kind of try and fit it into an hour and a half or 2 hours. And I think we ended up with 17 presentations from across about 12 different countries. So I'll give you some of the highlights here. We had two keynote speakers in this event, Amy Kirby from the CDC to talk about the National Wastewater Surveillance Program, and also Hirchen Medema from KWR to talk about how KWR will continue to advance wastewater surveillance in Europe. And so at this time, the National Wastewater Surveillance Program had been doing their pilot for some time. I think they had 5 or 6 sites in the pilot. Amy was basically able to confirm that, wastewater surveillance was being used as an independent confirmation of the trends in illness in the community, whether it was going up or going down. They particularly were interested in trying to use it where there was limited clinical testing data available. And they know that it was giving them like a heads up as to what was going to happen at a hospital. So the wastewater surveillance results were tending to give them a week to 2 weeks advance warning that infections would be increasing in a particular area. So it was definitely being used as an early warning of changes in the level of disease in the community. What she emphasized at this time was that it still could not be used to estimate community prevalence or point prevalence. There just wasn't, there isn't sufficient data to do that. She also highlighted that they saw it as being part of like the health toolbox. So she was particularly keen to point out that one of the advantages is that it is independent of healthcare seeking behavior. So even if people don't want to go and get tested or aren't able to get tested, they're still going to the bathroom. So the wastewater is still there and can be tested to see what's going on. At this time also too, we were more aware that there were subclinical infections, so that there were people who were infected with COVID-19 but didn't necessarily know that they had COVID-19. So, weren't going to get tested because they didn't realize that they were actually ill. And it was picking up, wastewater would pick that up. And it was effectively a pooled sample. So, comparatively cheap to analyze a sample from a wastewater plant representing hundreds of thousands of people. Even testing that twice a week is comparatively cheap compared to having to go out and do 300,000 swab tests or something. So that was a significant advantage of the approach as well. And it also meant too that they were getting this early warning of what was happening in the population as well, rather than waiting for cases to turn up at the hospital. I'll just jump into now some of the examples from around the globe, because there's some really interesting and different approaches that people were taking to use the data and to actually apply the technique. So this is an example from the Catalan region of Spain. This group were at one point in time actually getting up to 80% coverage of their served population by the sampling that they were doing. And then they were using the N1, N2 and a different gene as well, the RDRP gene. And between those genes, they were tracking the trends in incidence in the population, the trends going up and down, and showing it on these dashboards. We've just color coded to indicate which areas were increasing levels and which areas were decreasing levels. And this information was all publicly available to the public. So quite an interesting and very open approach. This is an example of some work that was being done in France. Again, they were using the N1 and N2 genes, but also the E gene and the RDRP gene as well. The viral recovery yield was about 5%. So that was reasonably typical at that time as well. Again, they noted that N1 appeared to be the most sensitive biomarker, and a lot of people, I think, agree with that the N1 primer set is very good for detecting SARS-CoV-2. And they found that the protocol they were using was pretty operationally quick and easy to implement. So they were using this quite widely in France. And this was Veolia that was doing that work. And they run quite a few plants, obviously, in France. This is a more local effort. This was done in Colorado, in Denver. This was a collaboration between the university, Colorado State Uni, and also some of the water utilities there. And again, they put together a very nice dashboard, which was all color-coded to show whether it was increasing or decreasing levels. And they were comparing like the rolling average of the signal over, I think it was 3 sampling points at a time. And what was quite nice about this one as well is that they had mapped, using the GIS layers, they had mapped the sewage collection systems. And so that's how they drew the boundaries of where these different levels are. So they were actually doing the sampling at different locations so that they could split out the different nodes of the sewer system. So quite a nice piece of work there. This is another study done in Utah. And again, this was a collaboration. So 3 of the main universities, Utah State, University of Utah, all coming together and looking at what was happening. First of all, I think they were looking at their campuses, so looking at facilities on their campuses, and then they gradually expanded the projects through 4 different phases. And they were using this information to make decisions about whether or not to let students back onto the campus, whether to ask students to isolate. And they did have detections in dormitories, and then they said to people, okay, they detected, then went in and swabbed all the people to find out who was actually infected. And so they were using this information actively to manage the student population that was coming onto the campuses. So, and they had CARES funding for that, which was, so they got organised pretty early and got that funding and had that all in place. And about this time, people were starting to also look to see if the methods could be used to detect the variants. Initial thoughts were that it might be too hard to detect the variants in wastewater because they felt that the fragments of genetic material in the wastewater are actually pretty small, so pretty small snips of material. And so it was felt that might limit the ability to actually track the different genomes, and that there wouldn't be enough sensitivity to do that. However, it does appear that you can do that. And so people did start looking to do that and starting to see whether they could see the changes in the different variants that were coming through. And one of the first water utilities to really jump onto that was the Southern Nevada Wastewater Surveillance Program. So Dan Garrity and his team were able to detect the UK variant of concern, B117, in wastewater prior to any clinical infections actually being detected at the hospital. So they actually picked it up in the wastewater before the clinical cases were actually confirmed. So a really interesting situation where they were actually able to track what was happening and what the trends were. And then they subsequently also detected the California variant of concern as well in this project that they're doing. And they are still doing method development. They were part of our round robin laboratory methods comparison trial. And this group continues to develop their methods. And I believe they've got digital PCR set up now. So it's a pretty advanced group that they've been doing quite a lot of work since, and I was talking to Dan the other day, he said they actually started their program in February 2020. So they're one of the earliest groups to start implementing the wastewater surveillance. And we included this approach as well. This is an example, Dave McCarthy and his team from Monash University in Australia, where, as you know, Australia is a pretty big country like the US, but it's much less populated than the US. And so you have much less population spread out over equally large areas. Can be very costly to try and also time consuming to try and get those samples from these different communities. So one of the approaches that was looked at was, could we use passive samplers to detect the presence of the virus? So deploy sample collection devices out in the sewer mains, leave them there for a couple of days, come back a couple of days later and take them out. What they did was that they started out using more swabs and more traditional kind of swabs, but then they quickly realized that was really hard to get the viruses back out of those swabs, and they're pretty cumbersome to kind of deal with. So what they did was they made a 3D printed plastic kind of little missile container, you can see there in the picture, using a 3D printer to print that out so they can make them really cheaply. And they put the actual HA filter membrane inside the plastic device. So basically the membrane is in there, and all they have to do when they get the device back is pull it apart, pull the membrane out, and then take it straight into the lab analysis. So it made it a lot quicker and a lot easier to actually collect the sample and, reduce the amount of handling and reduce the need to have to extract and all that kind of stuff. So they've made these, the patent for the 3D printed devices freely available. Dave will give it to anyone that wants it. You can download it off the internet. And so they started deploying all these passive samplers. They compared the passive sampler results and found that they were getting good results with that. So there were occasions where the passive samplers detected, positive detection of SARS-CoV-2 when grab samples were missing it because they were picking up some of these intermittent flows. So that's a very cost-effective approach that can be used, particularly where you don't have a lot of illness occurring and you're looking to see if something's going to pop up again. So that's how they were using it in Victoria. So I'll just pause there if there's any questions. If not, I can summarize some of the lessons that we've learned through those first, I guess, 2 years. Okay, so I guess by the time we did that global update, we also sent out a survey to folks, and we realized that most people were using the internal controls. Most people were using bovine coronavirus or OC43. A lot of people were not adjusting for recovery efficiency, so they were just using the internal matrix spike to have confidence in their recovery results, but they weren't worrying about correcting the level of the signal. Most people were using the CDC N-gene primers, and often they'd throw in another one as well, either E-gene or something else. Most groups were starting to need high throughput and short turnaround time. So the ones that needed that were tending to use digital PCR rather than qPCR. And by this time as well, commercial kits were starting to pop up on the market, and people were able to either use a commercial kit or at least use a commercial kit for part of their method process, which was helping to streamline and speed up some of the testing and some of the results. And the passive samplers were being used to detect low levels and or to capture infrequent events and to monitor for hotspots. The other thing was that by this time we were very confident in the ability of the methods to be able to detect the trends in infection up and down. There's still some, I guess, variation in the level of early warning that it gives you. CDC and KWR are saying that they think it gives you about 6 days early warning before notice of when clinical samples or clinical people are going to turn up at the hospital. Over in South Africa, WRC thinks that it's as much as 2 weeks advance notice. So it's a little bit of a difference, but maybe that comes down to methods, and maybe it relates to how effective your hospital system is and how likely people are to go to hospital and things like that. So it certainly is an objective population surveillance, and it's independent of human test behaviour. So it means you can go and get these samples whenever you want, pretty much, and depending on your budget and how much money you've got to spend on it. But it certainly is also feasible to detect variants, and that has been really important in terms of tracking these different waves of COVID that have come through with the different variants. In some cases, we've seen that one new variant will displace the existing dominant strain within a week to 2 weeks. So it tends to be very quick when the new, particularly the more transmissible strains have come through. We've seen the change in the wastewater dominance of the strain actually change in as little as a week. The population size, one thing to note though, is that the population being sampled and population represented by the sample at your wastewater treatment plant does have some impact on the signal dynamics. And I'll just go to the next graph to show you that. And it's important to kind of bear that in mind when you're designing your sampling program. So sorry for the Dutch wording at the bottom. I'll just translate. Basically, look at these numbers here. So the pink is the 32,000 served, 300,000 odd people being served at that plant. When you get down to like this black line, which is like a plant servicing 5,000 EP, the signal just becomes a lot more clunky. Basically, you're more susceptible to seeing those peaks and troughs. So it just means that you get a lot more noise in the genetic signal when you're sampling from a plant that is serving a smaller population, and that's probably not unexpected. You're basically looking at a much larger pooled sample here, so it does take out some of the spikes in the signal, and so that's just something to be aware of when you're designing a sampling program. How big is the population area that you're serving? If you are sampling a smaller plant, you're likely to see these bigger dips and variations in the signal. In terms of the health decisions, one of the challenges has been that while this method works really, really well for centralized wastewater treatment plants, you can go and get a sample that represents, 300,000 people, 50,000 people. It's very difficult to then apply this technology where you have decentralized wastewater systems predominantly. And so, that was one of the challenges in applying this approach in, say, areas that do not have they're not connected to the sewer. You then have to work out, well, okay, do I go and sample? How do I go and sample for that? And so a variety of different approaches have been taken. In one of the studies they did in South Africa, they went around and they looked at the community on-site systems. So instead of trying to go to individual homes and sample on-site systems, they went to the community buildings in those communities where people would go to the town hall or they would go to the community centre. And so it was still an on-site system, but it was getting more of a pooled sample representative of that population because people were visiting that location. So that's one of the approaches that has been taken to try and be able to use this approach with on-site systems. You do have to be careful to not assume that negative results are indicating the absence of cases. That might not be the case depending on how sensitive your method is. If you have low incidence, it might be below the level of detection depending on what method you're using. So you can't sort of clear a community based on this. It is really a broad brush methodology. And in terms of pre-treatment sometimes of sewage may also affect the signal, and so some of those disinfection activities we don't know whether they affect the signal or not. However, a recent publication by Mark Sobsey, a well-known virologist here in the US, who's done a lot of work with the foundation. He's just recently published a paper and he's looked through all the documented evidence published in the literature, and he believes that there is no evidence that there is infectious or replication capable SARS-CoV-2 in fecal wastewater or water. And so that is a very important finding. We've kind of suspected that sort of after the first 6 months, we could see that, people at wastewater treatment plants were not getting sick. It was not like a higher rate of illness. And so we suspected that was the case, but it's very nice to have this publication just come out very recently from a very well-respected virologist who has gone through all the data and says there's no evidence that that SARS-CoV-2 infectious virus is in wastewater. It's a big thumbs up. I agree, Preston. So that is really very reassuring, and we know a lot more now about the virus than we did 2 years ago. That is for sure. One thing that we still don't know, though, is what is the infectious dose of the virus. So if you do have, a person who is coughing, or how much is coming out in their droplets, and how much someone needs to then breathe in order to become sick, we don't know what that infectious dose is. We don't even know if that's different for different variants. We don't even know an overall infectious dose number. And so because of that, you can't do a quantitative microbial risk assessment of what is the risk of catching COVID-19 at this point. I think that's going to be the work for future medical virologists and epidemiologists for some time yet, to try and get a handle on that number. I would expect, particularly for the Delta variant, that the infectious dose is probably actually pretty darn low, because certainly when Delta variant got into Australia, there were people who had very fleeting contact with the initial person who brought the virus in, and they got sick. Fleeting contact. So it's probably a pretty low infectious dose, at least for some strains, but we don't know yet what it is. And I do think, from a water sector perspective, knowing that the virus genetic elements that are in sewage are not infectious is a really important finding. In terms of where next and where we're up to now, it is, sewage shed surveillance and wastewater-based epidemiology has been widely implemented now, and it is seen and recognised as being a valid complement to the collection of clinical data in order to actually make community assessments or to base decisions, health-based decisions on tracking and managing COVID-19. And so I think that is an amazing achievement, really, and that the water sector should take a lot of credit for making that come about. We know that different approaches can be used, and that it's appropriate to use different approaches depending on what phase of the epidemic you might be in, what available resources you have, and also what are the health objectives at that time. Is the health objective containment, or is the health objective something else? It does provide a leading indicator of what level of infection is occurring in the community, but we still don't have sufficient data to do a specific point prevalence number or calculation. But I think we've shown that that doesn't really matter. Actually being able to just track the trends has been sufficient to really help health authorities manage the situation. And what people are now looking at is, okay, if we're going to continue to do wastewater surveillance, what additional value can we get out of doing wastewater surveillance, and can it be used to monitor other things, for example, antibiotic resistance elements in wastewater. And we do know, of course, that you can track poliovirus. It's been used for decades to look for poliovirus in an unvaccinated population to see whether wild-type polio is there, and then also to monitor for Sabine virus in wastewater to see what level of vaccination you get when you're doing a vaccination program. So we know that it's easily able to track poliovirus. We do know that you can also use it to detect other virus outbreaks, so norovirus in particular, hepatitis A and E viruses. You definitely can track what the level of virus is that's circulating in a population, and it can also be used for early warning for some of these other pathogens as well. So that is definitely a possibility, and I think if CDC is going to continue to do wastewater surveillance, then being able to simultaneously check for some of these other pathogens and community health indicators will be very useful. I guess the remaining research needs are really just to kind of work out what other factors affect the signal strength in wastewater for SARS-CoV-2. If we could get a better handle on some of those factors, it might, while we might not be able to go to a specific community point prevalence estimate, we might still be able to standardize the data a little bit more and make it a little bit more comparable from different regions to different regions. And that would be certainly something that CDC, I think, would be looking at very closely, because if you're doing a national surveillance system, then you need to have a way to kind of normalize the data across these different areas. There is, I think, also a need for some increased sensitivity if we are wanting to track as caseloads decline, and be prepared to then pick up hotspots as they emerge. If we do get another wave, you do need probably more sensitive methods. So there is still some method development work that's happening there. And certainly being able to monitor for new variants is definitely something that I think monitoring wastewater is a very cost-effective way to keep a handle on the situation and to monitor what is actually going on. And I think it is worth having, the discussion around what is the health benefit of using wastewater surveillance to monitor community health for SARS-CoV-2 and other pathogens and health indices. And I think it actually is a very cost-effective way of doing that. So hopefully that is one of the things that we have learned out of this whole experience. Last slide is just, I thought I would mention, because I know in New York, there might be some of you that are aware of this. There has been reports of some unknown sequences or genetic lineages that have been found in the New York area, and also some have been found in Missouri. They're interesting sequences in that they're not actually being detected in human clinical cases. So it is hypothesized at the moment that there is a possible animal source that is contributing somehow to the wastewater system, and that we're picking up these sort of strange sequences that don't seem to kind of fit. It doesn't appear to be a widespread phenomenon, and there are a number of research teams that are looking at that and what the potential sources of these unknown sequences are. There is also a theory that it could be, the development of new strains or new variants occurring that's being detected that might be happening in an animal host. Really hope that's not the case, but we don't know yet. So I do know there are a couple of research teams that are looking at that at the moment to just see if they can figure out what's going on there. And that's where things are up to with SARS-CoV-2. Wastewater surveillance.
We do have one question in the chat so far from Preston. So it looks like wastewater surveillance would be an important source of metrics for early warning, leading indicator of trends, warning of new variants, cheaper, better than positivity rate that was relied on heavily for decision-making for public health response. Can you comment on that?
Yeah, look, I think that's absolutely right. It really is quite cost effective compared to going out and having to do individual swabs or individual clinical samples for every person in the population. I mean, if you can sample a wastewater treatment plant, cost you $300, $400 to do a PCR analysis, from beginning to end, you're getting a good understanding of whether there is a lot of illness in that community or not. And it's effectively a pooled sample, and it's not, there's no bias in that sample. It's like if your home's connected to the wastewater system, you're in there. It's not relying on particular people to come forward and be willing to be tested. And so I think there's a whole significant advantage to testing wastewater in this way to really monitor community health. I think very early on in the piece there were some concerns expressed by some folk that this could be kind of an invasion of privacy, but really you would have to be sampling the sewage system down to individual blocks to really start infringing on people's privacy. And I think even when that example I gave for Denver in Colorado, where they broke the sewer system down into chunks and were mapping the trends in different areas, it's still looking at 5,000 or 10,000 people in those areas. It's not like there's just 5 people living there. It was being used in a way that was not going to infringe on people's individual privacy. It was being done in a way that was going to inform people in a community, though, if they needed to be wearing masks and taking precautions. So I think it was very helpful. And I think that out of this whole experience, I think it has certainly brought the water sector and health professionals, epidemiologists, closer together to see that they can work together to actually help manage public health in a really proactive way. And I think that has been a real silver lining out of this whole event. And I'm very hopeful that that's going to continue. I think it would be a very positive thing if that collaboration could continue.
We have a couple more questions that are in the chat. One from Dennis. How did you find acceptance of this sampling or the results by local or county health departments?
That's a great question, Dennis. And it really varied from place to place, town to town even. So I think initially it would be fair to say that the health the health community were skeptical that the data could be used and that it would be reliable. And so that's why the studies we did were really important to really define the reproducibility, to put in place, controls, and to identify, how the methods could be made consistent, what you needed to do to make the results consistent. And I think what really helped was when, in a couple of individual situations, in particular places where it was being applied, where they actually got detection in the wastewater before they got clinical cases being detected. And they were able to show those results coming through in the wastewater for, a couple of days, and, had a couple of points saying, there's people here that are getting sick. We're seeing this. You're going to see people come to the hospital. And then people turned up at the hospital. And that's when the health authorities went, oh yeah, you're right. That did happen. And so by getting that weight of evidence of putting some of those cases together, individual health professionals actually were like, oh yeah, okay, I can see what you're saying. This does actually, like, they could see that it was lining up. And so having those individual cases publicized and shared meant that people started to hear about it and to go, oh, okay, it worked over there. Maybe it'll work here for us. And so I think initially there was a lot of skepticism, and I've seen footage of back in Australia, our New South Wales health minister saying, on video, just basically saying, yeah, I didn't think it would work, but they showed me the data and it works. And so that was really quite, it was great, because then the public as well were really confident as well. And so the Department of Health then in New South Wales was putting out their dashboard every week saying, we've detected SARS-CoV-2 in the wastewater at this treatment plant. So all you people in this area, if you have any symptoms, go and get tested. And so it really was a very, positive experience. And by sharing that information, it really, I think, helped build the confidence in the medical community that the information could be used in that way. And I know both New South Wales and Victoria health ministers were originally skeptical, but both of those health departments came on board and were basically using the wastewater data to help inform their actions of where to deploy mobile testing vans, where to put out messages to the community to say, go and get tested if you have any symptoms. If you've been in contact with somebody, get tested. If you're positive, stay at home, all that kind of stuff. So they were really using it to define their communications to the community about what the community should be doing at any point in time. And then they were also behind the scenes working closely with the water utilities to track where it was emerging, and then to modify their sampling plans to be going to pick up as it spread where it was getting to. So I think it's, it was pretty tough initially. I think people struggled to get their health communities on board. And I'd have to say, not everybody's on board yet. But I think a lot more people are on board than what they were at the beginning of the epidemic. And I think it's been, one of the most exciting things really is to have these conversations now happening between health professionals and the water sector to say, this is really how this information can be used. It's a big win, I think. Great, thank you. Thanks for the great questions.
Thank you for your time today. It was a great presentation, and we will send you those other questions so that you have them so we can get back to some of our members.
Yeah, love to. Thank you. Thank you for the opportunity to speak with you all.